Great, thanks, Cynthia. Because really, this morning's headliner, we're lucky enough to have Dr. Kevin Fenton, who's been the director for 7 years. I was surprised it had been that long, of the Center for Disease Control, Center on HIV, STIs, and Viral Diseases. Prior to coming to Atlanta and heading the CDC HIV portfolio, he was in the United Kingdom, where he ran the Health Protection Agency on HIV, STIs for the UK. He's a passionate prevention and research policymaker now, and firmly committed to issues around health inequities. And this morning, he's going to talk to us around CDC and CDC's agenda on the new and breaking news of treatment as prevention. Dr. Fenton.
Thank you very much, Mary Jane. Good morning, everyone. Welcome to Atlanta. It's fantastic to see all of you here, and as you've heard this morning, great to see you all so early on a Sunday morning, just before the beginning of the 2011 National HIV Prevention Conference. I hope that all of you in the room are not just attending this meeting, but that I will indeed be seeing you throughout the course of the next 3 days at a National Prevention Conference, where I think we have a fascinating agenda to reflect on HIV prevention in the United States, but also to talk about some of the challenges of where we are currently in our response and our scaling up of our interventions to addressing HIV in the United States. Let me begin by just thanking the organizers for giving me this opportunity to welcome you all here in Atlanta and to provide the kickoff opening presentation for this exciting meeting. Unfortunately, I won't be able to stay with you for the entire course of the day. We have a number of other pre-conference events that I'll be attending. But I did want to begin the day by talking about what I think is one of the most exciting developments over the past few years in the HIV prevention field. And for the presentation this morning, I'd like to take a somewhat different tact. I would like us to both reflect on where we are with the epidemic of HIV/AIDS in the United States today, and to think about treatment and prevention within the context of the worsening health inequities that we're now seeing as far as HIV is concerned in the United States. As many of you are aware, CDC released data only a week ago regarding the stabilization of HIV incidence in the United States, and yet within the stabilization were worsening trends among men who have sex with men, and particularly men who have sex with men of color. So I'm going to be speaking then about the promise of these new technologies, why I am concerned that these new technologies may actually worsen health inequalities if we are not careful and deliberate about the ways in which we implement these new technologies moving forward. So I'm going to be speaking about where we are with the epidemic of HIV in the United States today, to really pull the data together to provide that context, which I hope will serve you well for the next 3 days at this meeting. And then I'm going to reflect on treatment as prevention, where we are now, what are some of the implementation issues, and why health equity needs to be a major concern moving forward. And then finally, reflect on some strategies that we are putting in place at CDC, but certainly which I think you should be, and I know you are putting into place, to really be much more mindful about health inequalities and these new biomedical preventions moving forward. So let's begin then by just reflecting on the epidemic. And I know that this slide will be familiar to all of you in the room. It really gives a pictorial overview of where we are with the prevalence and incidence of HIV in the United States. As you know, there are nearly 1.2 million Americans currently living with HIV. About 1 in 5 of those individuals are unaware of their HIV status. We have been seeing relative stabilization in HIV incidence in the United States over the past decade, at about 50,000 new HIV infections occurring each year. But that stabilization in HIV incidence hides a number of trends which are happening across behavioral subgroups within the United States. And I'll be unpacking some of those changes in further slides in this presentation. Now, the fact that we're seeing increasing prevalence with stable incidence probably means that the transmission rate for HIV in the US is actually declining. In other words, with more people living with HIV, we would naturally expect a higher probability of onward transmission of disease and therefore increasing HIV incidence. But the fact that the incidence is staying stable, it probably indicates that people who are living with HIV are both taking steps to prevent onward transmission of the disease, and we're beginning to see the population manifestation of the highly effective antiretroviral therapies, which are reducing onward transmissibility of the infection. We also know that looking at prevalent disease within the United States, we see tremendous geographic concentration and heterogeneity, and this is becoming an increasing hallmark of the US HIV epidemic. This slide shows the geographic concentration of prevalent diagnosed HIV infections in the United States. And as you'll see in the following slide, when we look at prevalent infection in the US, we see tremendous evidence of geographic concentration. Today in the United States, 95% of individuals who are living with HIV/AIDS are either men who have sex with men of all races, African Americans, Hispanic or Latinos, or injecting drug users. Men who have sex with men are 40 times more likely to have prevalent HIV diagnosed infection than other men and women in the United States. And we know from the data on diagnosed HIV infections that African Americans are 8 times more likely and Latinos 3 times more likely to be living with HIV than whites in the US. The geographic concentration of the disease is further illustrated here. 54% of persons living with AIDS in the United States actually live in 5 states, and 90% of persons with AIDS are actually in 23 states in the US. These issues really have tremendous impacts on the way in which we're conceptualizing prevention, treatment, and care for HIV in the 21st century. And not only are we seeing the sort of geographic heterogeneity by states within the US, but within these states, we're seeing clear evidence of concentration of the epidemic among urban, socioeconomically deprived communities, where the prevalence of HIV is high no matter your risk group, no matter your race or ethnicity. So if you're poor, living in poor urban areas in the US, you're likely to have high HIV prevalence if you're black, white, or Hispanic. So again, these are clear hallmarks of the evolution of the HIV epidemic in the United States. Now, we can focus on prevalent disease to tell the story of HIV in the US, but I think it's also critical that we reflect on the leading edge of the epidemic by focusing on HIV incidence, or where new infections are actually occurring in the US. And I thought I'd spend a little bit of time, because these data are still so new, to unpack the latest data on trends in HIV incidence in the United States. Now, as you've heard from recent releases from the CDC, HIV incidence in the US has been relatively stable over the last 4 years, at about 50,000 new HIV infections occurring in the US per year. Within this, we see tremendous differences across the racial and ethnic groups. A key feature of the HIV incident infections is the remaining burden of disease, especially among African Americans and Hispanic and Latinos, relative to whites in the United States. And in this slide, you're able to see the trends within these groups, stratified by gender, between 2006 and 2008. And I'm sure you'll agree that for each of the gender and race categories, we see relative stabilization in the trends in HIV incidence over time. Another way of looking at the burden of new HIV infections is looking at where these infections are occurring by race and transmission category in the US. And I think this tells yet another story on the leading edge of the epidemic, with white men who have sex with men having the most numbers of new HIV infections estimated to occur in the United States in 2009, followed by black MSM and Hispanic MSM. So looking at it pictorially, we see that men who have sex with men still account for the overarching majority of new HIV infections within the US. The next group of infections are occurring among black heterosexual women, black heterosexual men, and Hispanic heterosexual women, followed by much lower numbers of infections among injecting drug users. Now, HIV incidence in drug users in the US has certainly been one of the success stories of our prevention efforts. We've seen a near 80% decline in HIV incidence in injecting drug users since the mid-1980s. However, we're continuing to see this disproportionate burden of new infections occurring among men who sex with men. So we can further unpack this leading edge of the epidemic by looking at different characteristics of individuals who are becoming newly infected to tell the story of health inequalities. So we could look, for example, at the gender distribution, where we see that nearly 77% of new infections are occurring among men in the United States compared to 23% among women. We can look at the leading edge of the epidemic to see that we're still seeing a disproportionate burden of new infections occurring among African Americans. Nearly 44% of new HIV infections occurring among African Americans, 32% among whites, and about 20%, 1 in 5 new infections occurring among Hispanic and Latinos. Again, we can look at the heterogeneity by age group within the United States, where we see, in contrast to earlier reports from the CDC on HIV incidence, we're seeing an increasing concentration of new infections occurring, especially among the younger age groups, those aged 13 to 29 years, with lower proportions in slightly older age groups in the United States. Again, we'll be unpacking these data in a little bit more detail. And finally, we can look at the distribution by transmission category in the US. And again, we see a further concentration of the epidemic among men who sex with men. 61% of new HIV infections, which are occurring today in the United States, are occurring among men who sex with men, and nearly 1 in 3 among heterosexuals, and about 1 in 10 among injecting drug users. So we're seeing continued declines in HIV incidence among injecting drug users, increases in men who sex with men, and of course, a relative stabilization in incidence among heterosexuals in the United States. Now, I'm going to focus in a little bit more detail on the trends among men who sex with men, because this is perhaps where we're seeing the most dynamic changes in HIV incidence in the United States. And this first slide really shows the estimated numbers of new infections among MSM by race, ethnicity, and by age in the US, and really shows the very distinct characteristics of the burden of new infections by age group within each racial category. So if we look, for example, at the green bars, at white men who sex with men, we see a fairly even distribution of new infections occurring in the 13 to 29, 30 to 39, and 40 to 49 age groups. Contrast that to the pattern which is observed among black men who sex with men, where the majority of new HIV infections are actually occurring in younger men who sex with men, those aged 13 to 29 years, and lower numbers of infections occurring in successively older age groups. Among Hispanics, we see a pattern which is more akin to the pattern seen among black men who sex with men, although the overall number of new infections are somewhat lower than white and black men who sex with men. Finally, one of the things not to lose here is that because the population of black men who sex with men is substantially lower than white men who sex with men in the United States, the overall rates of new infection are likely to be far higher among black men who sex with men than white MSM, even although the numbers of new infections which are occurring each year are relatively similar. Now, what's happening in terms of trends within each of these age groups or racial groups among the younger groups of men who sex with men within the United States? This slide focuses on the 13 to 29-year-old age group and looks at men who sex with men who are black, Hispanic, or white in the United States. And again, I don't think you need to be an epidemiologist to see that among the Hispanic group as well as the white group, we see relative stabilization in the occurrence of new HIV infections over time. But the most dramatic increases are being observed among young black men who sex with men, aged 13 to 29, where we're seeing substantial increases in HIV incidence over time. So I think we need to step back and we need to again ask ourselves, why are we seeing these appearance of worsening health inequalities in the United States, and what are the factors which continue to drive the epidemic and drive these health inequalities that we're seeing today? Well, I think a very good place to start is thinking about the social determinants of health model and thinking about this frame of thinking about the structural and social drivers and how they relate to individual level risk and the interaction with healthcare systems within any population to derive population health and well-being. And the WHO has developed this model which really talks about innovative ways of thinking about social determinants of health. So the WHO model unpacks the individual characteristics by focusing not only on behaviors and psychosocial factors and biological factors which can increase the risk of disease acquisition or health inequities, but talks about the social hierarchy and how that in turn influences both the ability to purchase health, avail oneself of health, or to take advantage of health within a given society. So factors such as level of educational attainment, your occupation, your income, your gender, your race, ethnicity are clear factors which influence your position in the social hierarchy and therefore your ability to obtain health. Clearly, the model talks about the social determinants of health, economic and political context, governance, policies which have an impact on health, and cultural and societal norms. And then finally, the model is very explicit in talking about the healthcare sector and the role of the healthcare sector in determining health. Now, I love this model. I use it to teach a lot. But as an infectious disease epidemiologist, I am dissatisfied because I think there are stories here which are not being told, which reflect the realities of HIV transmission in the United States and the inequalities that we're seeing for HIV in the United States. So, in a friendly amendment to the WHO model, I'm going to add a few things, and I hope you'll agree with some of the things I'll add this morning. So first of all, when we think about the social position of an individual and factors which influence how society reacts to that individual, I want to add to this sexual orientation and the experiences and the realities of LGBT populations, certainly here in the United States and around the world, and how factors such as homophobia have real and devastating consequences on the health of LGBT individuals in the US. We need to add to this homelessness, for example, and our ability to access healthcare services, as well as to think about ways in which we're able to address issues related to health and the purchasing of health within our society. Because we're dealing with an infectious disease, we need to think about who's having sex with whom or who's injecting drugs with whom, and therefore we need to think about sexual and drug risk, as well as mixing patterns within a population, and we certainly need to think about the structure, nature, and form of networks within communities which can facilitate the transmission of these infectious diseases. Clearly, because we're thinking about an infectious disease, we need to add to the model the background prevalence of disease, which is a huge driver of incidence. And I would argue is probably the main reason why we're seeing these very high increases among young men who have sex with men. Studies after studies have demonstrated that young MSM have equal or lower rates of high-risk behavior than their white and Hispanic counterparts. But they're having these lower risk behaviors within a context of very high background prevalence of disease, which I believe is in turn driving HIV incidence. I think we need to add the correctional system in the United States, which is a huge structural determinant of the health and well-being of populations and communities. And I think no model of the social determinants of health focusing on HIV should exclude the correctional system, where 30% of African American men by the age of 30 years in the US are going to have some contact with the correctional system in the US. I think we need to think about the effectiveness, the quality, and our ability to scale up the most impactful prevention interventions. So we're not only speaking about the healthcare system as a structure and thinking about access to the healthcare system, but we're thinking about the quality, nature, and form of interventions which are delivered in the United States. And finally, as we're thinking about the social determinants of health, let's add to this model and call out specifically racism and homophobia, which continues to determine the experiences of so many of our brothers and sisters and their experiences on HIV/AIDS in the United States today. And let's talk about residential segregation as a key determinant of who has access to what kinds of interventions, what kinds of opportunities in the United States today. So these are a few friendly amendments to the WHO model, and I'm sure many of you will have a few more to add. And we could have a lecture on our own on the WHO model of the social determinants of health. But I put this here to illustrate that we're dealing with a very complex reality of HIV in the United States. And as we think about new technologies, as we think about new biomedical technologies, it is critically important that we focus not only on interventions delivered in the healthcare sector, but we think about the wider range of drivers of health inequalities and what we need to be doing to address these issues. So, I think there are a number of implications for what we're doing in the United States as far as HIV prevention is concerned, given the realities of the epidemic and given the realities of the drivers of health inequalities. First, I think the concentration that we're seeing of the epidemic in the United States means that we have to prioritize, we must target, and we must bring to scale the most effective interventions for those who are most at risk of acquiring HIV in the United States. A blanket approach to our prevention efforts will not do. And we need to move beyond the platitudes of thinking that everybody needs everything at the same time. We do not have the resources to do that. We do not have the time to do that. And we need to be much more focused. Second, I would argue that the current economic realities, and certainly the current economic debates that we're having in the country, really dictate the need for us to use the available resources that we have wisely, that we must be unapologetic in targeting our resources, in aligning our investments with robust strategies, and we need to have different ways of monitoring and responding to the epidemic as we're moving forward to ensure that we are indeed making the differences we need to make in addressing these health inequalities. Thirdly, I would argue that because we know better, we must do better. If we truly believe that the determinants of HIV/AIDS and the inequalities in the US are indeed multi-layered, then it behooves us to ensure that we have a prevention portfolio which is in turn multi-layered as well. And so we need to be thinking about combination or comprehensive approaches for health impact. And then finally, I think we also need to be looking about how the external environment is changing, and in a transformed healthcare system, what are some of the opportunities that currently exist for us to either partner differently, to do different kinds of work, or to integrate the new technologies in more novel ways than we have done previously. What do we need to do to integrate these prevention approaches more effectively and indeed use these approaches to address health inequalities in a more deliberate way? So, in the second part of the talk, I'd like then to move towards treatment as prevention, having sort of told the story of where we are with the HIV epidemic in the United States, and I hope made it very clear that not only are we dealing with a dynamic epidemic, but one that is in danger of worsening health inequalities over time. I think I'd like to focus on where we are now with treatment as prevention and what are some of the health equity implications as we begin thinking about treatment as prevention. Now, it is very clear, and perhaps this is the big news in the prevention, treatment, and care field in the United States, certainly this year, that treatment is in fact prevention, that there is absolutely no doubt that plasma HIV-1 RNA level is perhaps the strongest predictor of the risk of HIV transmission, and our ability to effectively suppress viral replication with the appropriate use of HAART will be highly effective and is highly effective in reducing HIV transmission. And we know that this occurs whether we're looking at vertical transmission, prevention of mother-to-child transmission of HIV, whether we're looking at serodiscordant heterosexual relationships, or whether we're looking at transmission of HIV among injecting drug users. In addition, we know from the data that effective antiretroviral therapy also has an impact on managing or reducing the incidence of tuberculosis, benefiting people who are living with HIV/AIDS, and of course, potentially reducing onward transmission of TB to others. So as we incorporate these new findings, I think it's important that expansion of HAART coverage, really we're beginning to see areas across the country where as we expand HAART coverage, we're beginning to see decreases at the population level in community viral load, and this is consistent with some of the declines in new diagnoses which we're seeing in areas such as San Francisco, in British Columbia, and in Taiwan. So the evidence is becoming clear not only from our randomized controlled trials, from ecological studies, and from a range of clinical studies about the individual as well as the population benefit of antiretroviral therapy. Now, you will hear much more, I'm sure, throughout the day about the HPTN-052 study, but I think this was indeed the landmark study that laid to rest the debate on treatment as prevention. And as many of you know, this was a randomized controlled trial looking at serodiscordant couples, which was recently halted by the DSMB based on their interim analysis. The study enrolled HIV serodiscordant couples where the index member of the couple had CD4 counts between 350 and 550. Couples were randomized to intermediate versus deferred heart for HIV-infected partners, and the study found a more than 96% decrease in the risk of HIV transmission with immediate heart. And again, as I mentioned earlier, heart was associated with decreases in disease progression as well as death, as well as an 83% reduction in extramural tuberculosis. So we can put this all together then by thinking about not only HPTN-052, but the range of other studies which have become available in the last couple of years, which are beginning to tell the story of the role of effective antiretroviral prevention approaches as part of our prevention toolkit. This slide is courtesy of my colleague Dawn Smith, and it really illustrates and summarizes some of the data that we currently have from the variety of studies, from FemPrep, where we failed to demonstrate any efficacy in the role of oral PrEP for heterosexual women, contrasting that with the findings for tenofovir vaginal gel from the CAPRISA 004 study, a 39% efficacy. The IPREX study, looking at oral PrEP among men who have sex with men, a 44% efficacy. Adult male circumcision, adding to this other biomedical approaches, including oral PrEP in heterosexuals from CDC's TDF2 study, 63% efficacy, similar to the Partners PrEP study for oral PrEP in serodiscordant couples, 62%. Higher levels of efficacy for HIV-negative individuals, higher levels of efficacy seen in serodiscordant couples who are HIV-negative for Partners PrEP, as well as early ART in serodiscordant couples, HIV-positive, 96% efficacy for the HPTN-052 study. So again, we're seeing here the impact and the increasing impact of ARV-based prevention methods in the United States. So putting this all together then and thinking about the prevention toolkit, I think we have cause to celebrate relative to where we were 3 or 5 years ago. We have now a range of effective, randomized controlled trial proven interventions which can now be confidently added to the prevention toolkit. And as illustrated here, ARV-based prevention, including as well as daily oral PrEP, can now be added to the prevention toolkit. I think, therefore, that this really begins to change the very dynamic way in which we're thinking about the driver, the individual level factors which are driving HIV transmission within the United States at the individual level. So at the individual level, we need to think about factors which are related to your exposure to HIV, level of infectivity, or your susceptibility to the infection. For exposure, we know that this is related to factors which can increase the likelihood of exposure, which include high background prevalence, untested or undiagnosed HIV infection within a population, inconsistent or incorrect condom use, having multiple sexual partners, or having sex within a relatively closed communities, which in turn results in the interconnectedness of networks which facilitate exposure to an infectious agent. Clearly here, we need to be thinking about the prevention tools such as condoms and behavioral change as effective strategies to reduce the risk of exposure. To reduce the risk of infectivity, which may be the result of high viral loads within the genital tract secretions, which in turn are reflective of high incidence, untreated late infection, or co-occurring STIs, which can all increase infectivity. I think it's clear that we're beginning to see the role of ART as an opportunity to reduce the level of infectivity of HIV-infected individuals and subsequently onward transmission of disease. Finally, we could think about the factors which are driving susceptibility to HIV, including lack of circumcision, early sexual debut, as well as co-occurring STIs. And again, thinking about the interventions which may offer an ability to intervene at this point: PrEP, PEP, and male circumcision. Now, the key aspect to note here is that these interventions are not being presented as individual interventions for implementation, but we need to have conversations on how best do we combine these interventions, how do we use these interventions depending on the phase of the epidemic, how do we scale these interventions up so that we're having the appropriate coverage within target populations to have the appropriate impact on the epidemic, and how do we ensure that we're delivering these interventions in culturally competent and culturally appropriate ways to ensure that the randomized controlled trial efficacy patterns that we're seeing are actually translated into real-world effectiveness for communities that need them in the United States and around the world. So given then where we are with treatment as prevention, I think it's important that we should begin to merge the two. Let's now talk about why should we be concerned about health equity, given the promise and the excitement of treatment and as prevention. Some have argued that we have a new shiny object that we should be excited about moving forward, charging forward, implementing, and bringing this epidemic to an end. While not wanting to say that we should be cautious, I think we need to be mindful of health equity and health equity concerns. And for the purposes of this discussion this morning, I'm going to define health equity as the absence of systematic, unfair disparities in health or the determinants of health among population groups in a social hierarchy or with different levels of social advantage or disadvantage. And I'm going to be walking through some arguments why we probably, and we should definitively, be concerned about health inequities as we're beginning to think about rolling out treatment as prevention and other biomedical approaches in the United States. So, first of all, we are going to be implementing these new tools within a dynamically changing social environment in the United States, where HIV/AIDS is no longer the major item of concern for the US population, and indeed not even the major item of concern for people and populations and communities who are at greatest risk of acquiring HIV. And here we see data from the Kaiser Family Foundation illustrating that the proportion of Americans who feel that HIV/AIDS is an urgent health problem has declined from nearly 44% in the 90s to less than 6% in the most recent survey. We also see tremendous heterogeneity across racial and ethnic groups in the United States in terms of attitudes towards, or social attitudes, which can determine how new technologies are going to be taken up and implemented within communities. So whether we are speaking about the proportion of Americans who have ever spoken to a doctor about HIV/AIDS, ever spoken to a partner about HIV/AIDS, ever been tested for HIV, personally knowing somebody who's HIV infected or died from AIDS, feeling that HIV/AIDS is an urgent problem within their community, or being personally concerned about being infected, we see tremendous differences across racial and ethnic groups. Now, the good news in this slide is that communities which are harder hit by HIV tend to have higher population awareness and concern about issues related to HIV relative to groups which are less affected. So whether we're looking at the differences between African Americans and whites or Hispanic and Latinos and whites. I think the more concerning thing here is the overall, that for many of these indicators, we are still seeing a level of unconcern, I'm not sure if that's a word, a level of lack of concern, that's better, a level of lack of concern given the burden, prevalence, and urgency of HIV/AIDS within the communities. So for example, looking at AIDS as a more urgent problem in their communities, 60% of African Americans disagreed with that statement. Nearly 65% of Hispanic and Latinos disagreed with that statement. And looking at the proportion of individuals who are personally concerned about becoming infected with HIV, the bottom row of bars, again we see the overwhelming majority of communities which are hardest hit fail to have the level of concern which I think would be needed given the level of urgency with the epidemic. Now, these social attitudes matter. They matter. Because the reduced national concern about HIV/AIDS makes it far more challenging for us to maintain a national dialogue on HIV. It makes it harder for us to maintain population-level awareness, interest, and advocacy about HIV, and therefore will in turn make it far more challenging for us to both think about, fund, and scale up new interventions which are coming onto the market. These social attitudes are also important because if this is the social attitude of the general population, it is likely that key decision makers, those who are in a position to make decisions on how policies and programs are created and funded, are likely to have these attitudes as well. And this, in turn, will have tremendous impacts on the kinds of policies which are developed in the United States, the funding that we have for prevention, treatment, and care, the necessary leadership that we need from our political leaders, and the level of engagement that we need by our political leaders in communities across the country to make a difference on HIV. And these social attitudes are incredibly important because the most affected populations are in fact less likely to be vocal and more likely to be disenfranchised. And therefore, newer and more expensive interventions may be seen as less of a priority for implementation by those in power, especially if they're going to benefit marginalized groups within our society. And I'd love to hear your thoughts on this, but I see this on a day-to-day basis in the work that I do. And it's likely that you're seeing this in your communities across the country as well. Then we need to think about some of the real-world issues which are likely to affect how treatment and prevention is rolled out and scaled up in the United States. We need to think about ways in which new technologies are diffused in any given population. Now, the reality is that current prevention efforts can reduce new HIV infections, but we are unlikely to see the level of reductions in incidence which are going to be sustained and widespread in the epidemic in the US. And I began the talk this morning by showing you the stabilization in HIV incidence in the United States. So clearly what we're doing is not enough, and we need to be thinking about ways in which we should be scaling up our interventions. But there's a challenge here because as we're adding new prevention tools to the toolkit, the diffusion and implementation takes time. And we should not be thinking that these new technologies are going to be implemented tomorrow, the day after, or even next week. And we have wonderful examples of this in recent history. We can look at male circumcision and the time that it took from the ecological studies, the randomized controlled trials, and the real difficulties and challenges that we're having in the scale-up of male circumcision, even in the most hardest hit territories or countries globally. We can also look at prevention of mother-to-child transmission for HIV infection and the fact that it took nearly a decade for us to see some of the population benefits in many countries globally, and many countries in sub-Saharan Africa are still having tremendous problems in dealing with prevention of mother-to-child transmission of HIV, despite the fact that we have effective interventions, a target population, and an intervention process which should be relatively simple for us to implement. So I think the real questions then relate to how do we diffuse interventions? How do we accelerate the diffusion of interventions? And how, as we're thinking about diffusion of interventions, we should be mindful of health equity considerations in that diffusion process. So real questions then remain on how we integrate these new technologies, how we integrate them with behavioral and biomedical approaches, how we package them, and how we deliver them for greatest impact. Now, my colleagues at CDC have shared this slide with me as an illustration of some of the real challenges that we're likely to have with diffusion of innovation. And I'm sure you'll be discussing this even more during the conference today. Understanding that diffusion of innovation is, in fact, a process, and it does take time, and that we're likely to see diffusion occurring immediately among the innovators, or first among the innovators within our society, opinion leaders, early majority, and then you're going to have the laggards, those who which, for example, mother-to-child transmission. There's a reason why we're continuing to see nearly less than 100 new cases of HIV infections among infants in the United States today. And we need to think about process issues, structural issues, as well as professional issues, which continue to prevent the elimination of, for example, mother-to-child transmission or the adoption of effective prevention approaches within our society. Now, one could argue that we're getting better at adopting innovation over time, and the time that it took, for example, to scale up telephones, for example, within the United States, or get 100% coverage of electricity, or the use of the stove. That took place over decades in the United States, and clearly, I think we could argue that we're getting a lot better in reducing the pace of change and the diffusion of innovation in more recent times. So whether we're looking at the use of computer technology, the iPhone, the internet, and one could even argue Facebook. You name it. More recently, we've become better at diffusing new technologies and innovation. But the question that we need to ask is that, what are some of the factors? What can we learn from patterns of diffusion of innovation? And how does this impact what we're trying to do? Well, clearly, I think whether we're looking at treatment as prevention or other biomedical approaches, we need to think about who's making decisions for implementing these new technologies, who's funding them, and who are providing the policy and political context to allow the fusion of these interventions. We need to think about the prior conditions under which these interventions are going to be added. So as we're thinking about adding these prevention innovations to the prevention toolkit, what do we know about previous practices, the need for the problem, the felt need, the level of innovativeness, or social and system norms which can either facilitate or hinder implementation. And then finally, we need to also have conversations and real conversations about how the new innovation is being perceived, especially by the groups that are likely to benefit from these new interventions. Is there a relative advantage? Do African American young MSM feel that these new prevention technologies are actually addressing felt needs for the factors driving the epidemic within their communities, or can provide a relative advantage? Is it compatible with current behaviors or norms? Is it complex? Is it going to be too complex to incorporate into their daily lifestyles and therefore making a difference for uptake? Has it been trialed before adoption, and how visible is its use? And we have excellent examples where prevention technologies which are available for other infectious diseases have had a very difficult time with diffusion. So whether looking at the scale-up of hepatitis B infection among men who have sex with men, we have a cheap vaccine, a relatively cheap vaccine that we have been recommending for men who have sex with men in the United States for more than 20 years. And we're still dealing with poor uptake of Hep B vaccination among MSM in the United States and tremendous geographic heterogeneity across the country. More recently, we're seeing real challenges with the scale-up and implementation of HPV vaccination in young adult women in the United States, in contrast to some Western European countries which have had a far more aggressive and far more successful scale-up of HPV vaccination among young women. Again, I'm putting these here as illustrations of some of the challenges we're likely to see as we're thinking about the diffusion of innovation in the United States. Clearly, I think there are some other real-world implementation issues that we need to deal with. The fact is that we're not looking at health inequalities for HIV in isolation. We could look at effective tools which are available for other interventions where we're actually not doing a good job and where inequalities are actually getting worse. So whether we're looking at primary and secondary syphilis, where rates among blacks are 9 times higher than whites, and we're seeing tremendous increases in young black men who have sex with men. We're seeing a concentration of gonorrhea, for which we have effective treatments in the US, again among African Americans. For vaccine-preventable diseases such as hepatitis B infection, we're seeing severe and substantial racial and ethnic differences in the United States. And as we're doing a very good job in reducing tuberculosis, for which we have an effective treatment in the US, we're again seeing concentration of the epidemic of tuberculosis, again in foreign-born populations and among African Americans. Finally, I think we also need to reflect on real-world issues as it relates to the treatment and care cascade in the United States. Again, I'm sure you'll hear a lot more about this today in this presentation, in this session. But clearly, as we're thinking about who has access to effective antiretroviral therapy in the United States and who is virally suppressed, we see a tremendous fall-off in the United States between the proportion of individuals who are living with HIV and aware of their status and those who are actually on treatment and viral load suppressed. A key part of this is real-world concerns with even access to effective antiretroviral therapies in the US today, with waiting lists for AIDS drug assistance programs in the US of nearly 9,000 people currently waiting for access to effective antiretroviral therapies in the US. So if we're having challenges with providing antiretrovirals to people who are in need, to what extent are we going to be really concerned about thinking about the issues related to treatment as prevention in the US? At the bottom of this slide, I illustrate that of the 9,000 individuals who are currently on ADAP waiting lists, we see that the majority of the states with waiting lists are actually in the southern or southeastern United States. And you'll recall from my earlier slide on where the epidemic is becoming increasingly concentrated, it's in these states within the southern US. Again, we need to ask questions. Who has access and who are the clients who are not getting these new technologies? And here are some data looking at the profile of ADAP clients in 2008. Again, we see high proportions of African Americans, Hispanic and Latinos, high proportions of individuals living below the poverty level line. So let me pull this then together to perhaps argue why I think we need to be concerned about new biomedical interventions and their ability to improve or tackle health inequity. First, I think these interventions are complex and they actually rely on delivery through health systems which are already failing at-risk communities. So if we are relying on these biomedical interventions alone, we need to ask the question, are we adding these interventions to systems which are not meeting the needs of communities? Second, the new interventions are more likely to be taken up and diffused among those who are already engaged in healthcare and who have access to the new technologies, thereby compounding the inequalities which we are discussing today. Thirdly, the root causes of these inequalities are, in fact, a complex interaction between social and structural determinants of intervention, social and structural determinants. And biomedical interventions, I would argue, are likely only to address one component of the root cause of the health disparities that we're seeing. And if we are seduced into thinking about these interventions as shiny new objects for implementation on their own without thinking about context, then I think we will be adding to the health inequities. And then finally, I would argue that we continue to fail to learn the lessons from history and to proactively plan for culturally competent implementation of new technologies, in which we are a priori engaging communities and designing implementations for these communities, rather than relying on communities to fit into already broken systems. And again, I'd love to hear your thoughts on this, because we're trying to change the way we do business at the CDC to address all four of these issues as we're thinking about PrEP implementation, treatment as prevention. To what extent are these conversations being had at state and local levels? To what extent are these conversations being had in communities across the country to begin thinking about avoiding some of the challenges with health inequity with these new interventions? Now, in the final 5 minutes of the talk, I'd like to think about what are we going to do about this and how do we move forward in thinking about new ways in incorporating health equity as we think about effective implementation. Now, Julio Montaner, as he speaks on treatment as prevention, calls for smart heart rollout initiatives that incorporate strong implementation science component in which we're identifying best practices. Clearly, we're going to have to take a very critical look at the prevention, treatment, and care interface within the United States and to look at opportunities for optimizing processes within the US and to improve health outcomes. And you've heard from CDC, the NIH, and other federal agencies that these new technologies are fantastic, but now we need demonstration projects to look at the best ways of rolling them out and to ensure that we are incorporating and learning about health inequity issues moving forward. And equally important, as we're thinking about implementation, I would argue that we need to begin thinking about and planning for health equity in a way which is far more deliberate than we've done in the past. Tom Frieden talks about ways in which we should be thinking about the pillars of effective public health action, whether in the United States or globally. And I would argue that as we're thinking about addressing health inequalities, we need to infuse health equity conversations, perspectives, and actions in each of these pillars. So as we're thinking about program implementation, what are the health equity concerns as far as looking at ground level or practical details in key areas? How do we infuse health equity as we think about scaling up and optimizing interventions? Are our surveillance systems fit for purpose? Do they tell the stories and the realities of those who are most affected within our communities? And how do we ensure that we are able to change these systems to ensure that they're effective? How do we infuse health equity in our strategic policies as we're thinking about targeting and implementing interventions? And how do we build new coalitions which help us to address health inequities in different ways than we have had in the past? Clearly, partnerships are going to be critical, and outside groups to the government are going to be essential in thinking differently and achieving different outcomes moving forward. And then finally, I think we need to infuse health equity considerations in everything we do as we communicate and engage communities across the country with these new technologies as they're available. Now, we're not doing this out of context. There are areas where there are lessons that we've learned, certainly at the CDC, on how we can do a better job of targeting and scaling up interventions and engaging communities in new ways that we need to build upon. So whether we're looking at CDC's expanded HIV testing program, which for the first time we were able to specifically target testing among African Americans, men who have sex with men, Hispanic and Latinos, expanding this program over the last 4 years, and we have begun to see tremendous accomplishments in the US in terms of scaling up HIV testing among communities which are most in need of having these new technologies and linking the majority of people who have been diagnosed to care. We also have released new campaigns under our Act Against AIDS umbrella at the CDC, which was again launched 3 years ago, which really provide a whole new conversation about social marketing, leadership engagement in the United States, and engaging providers and communities in the fight against HIV/AIDS. So HIV screening standards care is one such initiative where we were able to look at culturally competent social marketing campaigns which met the needs of minority communities, minority providers, and spoke to the realities of implementation within the United States, looking at the epidemic for today. I think that as we think about implementation, we also need to think about ways in which we should be bringing this conversation on health equity and social determinants of health to the core of everything that we do. And CDC is committed to doing this. In the last year, we've released our white paper, or policy document on social determinants of health, entitled Establishing a Holistic Framework for Reducing Inequities in HIV, Hepatitis, STD, TB in the United States. We are arguing for and supporting a holistic approach to the design of public health programs to advance the health of communities and to increase opportunities for healthy living. And for those of you who haven't seen the white paper, I've included the URL here, and I'd really encourage you to view this, because this is shaping the nature, shape, and form of our prevention programs at the CDC. Now, in that policy document, we talk about the domains where we need to see change to make a difference with health equity in the US. And we talk about the role of leadership at national, state, and local level, the need for us to change the ways in which we are doing research and our surveillance programs, the ways in which we're thinking about communication and policy, capacity building, and partners. And I won't have time to go through these in any great detail this morning, but suffice to say that we again need to look at everything that we are doing in the way we design, implement, and deliver prevention programs, and look at opportunities for having the conversation around health equity and integrating the health equity perspective in these conversations. So, it's been a bit of a journey this morning. I really wanted to begin by ensuring that we were aware of where we are today with the epidemic of HIV in the United States, and that we are sure that our response today is fit for purpose, given where we are with the epidemic and given the nature of health inequalities and the worsening health inequalities that we're seeing in the US today. The evidence is clearly in. Treatment is, in fact, prevention. It prevents morbidity, mortality, and transmission. And we now need to find ways in which we're going to be incorporating it effectively into our prevention toolkit. I think the devil is indeed in the detail. The challenge really remains with implementation. We need demonstration projects. We need to begin to think about ways of incorporating these new technologies within our prevention toolkit, to think about the process of diffusion and to think about the process of implementation, and to ensure that we're doing these processes with the mindset of health inequities at the fore of what we're trying to achieve, not as an afterthought. And as we move towards diffusion and implementation, we must avoid worsening health inequalities during this phase. I've argued that we need to build upon the lessons that we've learned to optimize health impact as well as to effectively address health inequalities. We need to continue these conversations, whether at the national level, state, local, or community level, about health equity and concerns on health equity as we begin to think about new prevention technologies. We need to argue effectively that these new prevention technologies will only address health inequities if they're part of comprehensive and holistic approaches to addressing the epidemic within the United States, which results in a balanced portfolio of individual level, community level, and societal level interventions which are needed. We need to plan proactively for culturally competent access to these interventions and community engagement. And we need to ensure that our surveillance and monitoring and evaluation systems are fit for purpose so that we're not describing health inequities when they occur 5 or 10 years hence, but that we have real-time data that can give us the intelligence that we need to make mid-course corrections